Hello, good evening to all our beloved CCI members who have joined us for this webinar today. Good morning and good afternoon to our members who have joined us from various parts of the world. Before we begin this webinar, I have two very important announcements. The first is this is the concluding webinar of our CCI COPD webinar series. And we have selected a topic, a certain comorbidity in COPD that often gets overlooked, sarcopenia or muscle loss. So first we want to thank, appreciate and congratulate this course coordinator, Dr. Vijay Chennamchetty from Hyderabad. I got lots of good feedback in the last 2 months from our CCI Life members and other doctors who have seen our webinar that their thinking, their practicing of COPD has definitely altered by watching our COPD webinar series. They understand COPD better now. They treat COPD patients better now thanks to a webinar series. This feedback is very important for us in planning even more new webinars, even more exciting webinars. And the second most important announcement is 1 month from now, in the month of August, we have the CCI Con Kolkata. Dr. Rajadhar, Dr. Indranil, Dr. Shyam, Dr. Murli Mohan, they have been working very hard to execute a wonderful scientific program. I understand that today there is a plethora of scientific programs, but the team for CCI Con Kolkata have worked so hard that whoever will attend CCI Con Kolkata, you will find something new. This conference will not just be a copy paste of any other conference. In this conference, you will go and you will learn something totally new. Also, never miss the opportunity of meeting in person your CCI friends with whom you're talking in WhatsApp 24 by 7. So please mark your dates. We have been sending updates on the WhatsApp group regarding our CCI Con Kolkata. So let's hope to see all of you at CCI Con Kolkata. Now let's start talking about today's webinar. Myself, Atri Gangopadhyay, I come from Ranchi, Jharkhand. I am the East Zone Governor and National Spokesperson of Chest Council of India. So what is sarcopenia? Sarcopenia is loss of both muscle mass as well as muscle strength. There is an operational definition by EWGSOP 2018, where sarcopenia is a progressive, generalized skeletal muscle disorder associated with increased likelihood of adverse outcomes that can include fractures, physical disability, mortality. This term was coined very recently, as early as 1988, by a gentleman, Irving Rosenberg. And probable sarcopenia, there are certain criteria 1, 2, 3. Criteria 1 is probable sarcopenia, low muscle strength. If you add criteria 2, low muscle quantity or quality, that becomes a confirmed sarcopenia. And if there is a third criteria, low physical performance, then it becomes severe sarcopenia. The best example I could give you is this. A middle-aged person with obesity or pot belly, but look at below the thighs, how the limbs have shrunk. In sarcopenia, the picture becomes something like this. Now, loss of muscle mass is a physiological change of aging. 3 to 8% of healthy people in 30 to 70-year-old, 15% of healthy people who are above 70 years old, and 17.7% in critical conditions. Certain lung disease and sarcopenia are unfortunately related. COPD. These factors in COPD, where there is chronic inflammation, malnutrition, altered body composition, lower levels of physical activity, and reduction in muscle mass or strength, they are closely related to sarcopenia. So, if you look at the various pathophysiological mechanisms, neuromuscular junction loss, altered hormonal status, inflammation, malnutrition, inactivity, dyspnea, hypoxia, all they contribute to altered muscle cell signaling, which unfortunately contributes to decreased protein accretion, decreased regeneration, decreased oxidative capacity, and ultimately we have sarcopenia. Thus, all the factors in COPD are already present to create sarcopenia. Morphological and structural alterations have been reported in limb muscles in patients with COPD, and this coexistence is not less 21% to 63% of COPD patients. That is a huge number. Mitochondrial abnormalities cause problem in the oxidative capacity and they trigger the protein bake trauma. So basically, despite maximum bronchodilation, the patient feels सांसों की जरूरत है जैसे, or despite maximum medicines of COPD as per guideline, the patient is still breathless. And then you need to think that no, this person may be suffering from sarcopenia. Anorexia, chronic inactivity, hypoxia. Somehow, all these three are precipitated from COPD. Then, the smoke exposure and the systemic inflammation. It creates this chronic inflammation. Hypercapnia. COPD is a condition where we know that the CO2 rises. And that also causes a balance between anabolism, catabolism, leading to oxidative damage. All of these factors dysregulate cytokine production, leading to decreased muscle mass, decrease in the type 1 fiber. One treatment of COPD involves corticosteroid. That is also detrimental to muscle. And ultimately, we have decreased skeletal muscle function. Respiratory sarcopenia is a distinct entity. A decline in respiratory muscle mass and function. It is the presence of whole body sarcopenia, accompanying respiratory muscle mass and reduced respiratory muscle strength. So respiratory sarcopenia would involve skeletal muscles from the whole body as well as muscles helpful in the respiration like the diaphragm and the intercostal muscles. Diaphragm consists of type 1 fibers and type 2 fibers, out of which type 1 fibers are slow twitch, fatigue resistant. Type 2 fibers, fast twitch, power generating. In severe COPD, if you do a muscle biopsy, it shows higher proportion of type 1 fiber, around 71%, compared to healthy controls, 42%. So, the power generating muscles are lost. And this is an adaptive response to chronic respiratory load and need for fatigue resistance. Now, this fatigue activates sympathetic vasoconstrictors reflex, decrease blood flow to limb muscles, decrease muscle weakness. And this shifts circulatory demand toward respiratory muscles and away from limb muscles. Respiratory sarcopenia can be caused by various factors like aging, most important, decreased activity, undernutrition, disease itself, cachexia, sometimes iatrogenic like use of steroids. What are the key features? Loss of diaphragm mass and strength, respiratory muscle fatigue, impaired ventilation mechanics, and what may be the clinical consequence? It can lead to weakened cough reflex, poor sputum clearance. This can cause problem of aspiration. This can cause problem of a endobronchial lung collapse. Then increased risk of respiratory failure, which can delay weaning from mechanical ventilation. Third, contributes to sarcopenic respiratory disability, leading to reduced independence in daily life. So basically, when we understand sarcopenia, सांसें देकर अपनी संगीत अमर कर दो. So we can return the dyspnea relief back to the patient. Our COPD patient who was dyspneic despite medicine, who was feeling the सांसों की जरूरत है जैसे. After understanding sarcopenia, we can return back the breath. सांसें देकर अपनी संगीत अमर कर दो to the patient. Now, before we move on to the panel discussion, it is my privilege to introduce the participants of today. Today's panel discussion is presided by Dr NH Krishna from Davangere, who is the founder trustee and previous president of Chest Council of India. Among the panelists, as I have mentioned before, Dr. Vijay Chennamchetty, who was also the course coordinator from this CCI webinar series, and he is also the coordinator of all the webinars you see till now in the last 5 years. He hails from Hyderabad. Next, we have Dr. Pawan Gupta, a wonderful gentleman practicing at Delhi. And finally, we have a young Turk who is making lot of waves and lot of names in his district, Dr. Suyash Patil from Solapur. So now I would pass on the mic to Dr. NH Krishna, who will talk about something, and then we shall move on to the panel discussion. Thank you for the patience.
Good evening, my dearest CCA family. So this is a special webinar because it concludes with the COPD series, the part 10. However, Atri, wonderful presentation. As usual, you are the best. Happy to hear you always. Now, coming to the today's topic, we covered almost everything. Today. And later, when we felt that one topic is left, we thought of the sarcopenia. Now, I will tell you something before the panel discussion begins. A sound body can only support a sound mind. If you do not have a body which can respond to your mind, you could have experienced this. See what anxiety you have, what energy you have, what things you want to do. Since your childhood, they have persisted in the similar way in your brains, but your body will not support when you go on becoming old. That is it. So similarly, here in the illness, there are two things. One is the illness creates the muscle loss and disability, and this disability muscle loss, vice versa, it also increases the illness. So when such topic was chosen, we had already, we are all very well familiar for the reason that we know regarding the physiotherapy we are doing for COPD patients, beyond which we are also aware of decadurabalin and all were getting administered previously. Atri in his presentation also quoted regarding their side effects too. Now, when a new option is available in the market, how does that work? Let us see. And in the meanwhile, the intention of CC webinars has always been distributing knowledge to each and everyone, distributing whatever has come new to the market to the entire population of pulmonologists across India. That is the intention of CC webinars. So after hearing this webinar, you are very good to decide yourselves whether you can take this home or you can think about it and practice in your regular routine. So Atri, over to you. for the moderation regarding the panel discussion. So thanks for giving me an opportunity here wherein I could peep in and give my suggestion regarding the webinar. Thank you, everyone. Thank you.
Yeah.
Thanks,
Thank
Chennam,
you, sir.
Pawan Gupta, Suyash Patil. Thank you, everyone. Bye
You.
bye.
Thank you.
Yeah.
Thank you, sir.
Thank you for the inspiration. One thing which I always want to tell the clinicians, we may all be chest physicians, respiratory specialist, pulmonologist, but dyspnea can come from anywhere. And today, we are going to talk about some dyspnea which may be from the chest, which may not be from the chest. So, I would want to move to Dr. Pawan Gupta, who hails from Delhi. Dr. Pawan Gupta was a brilliant academician, and what I had heard that his notes when he was a student are still fought after by his juniors, who may be 10 years or 12 years junior to him. So meticulous they were. They were the interpretation of multiple textbooks. So, Dr. Pawan, how do you think the muscles contribute to breathlessness?
Thanks, Dr. Atri, for the great words, kind words, and selecting this topic. And you had a great talk. So, regarding the muscles contributing to the breathlessness, the thing is the many different clinical conditions we see which affect the and which causes the dyspnea, like the disease affecting the lungs, disease affecting the heart, disease affecting the neuromuscular apparatus. So all these can contribute to the dyspnea. So muscles contributing to the breathlessness, they occur by the participating in the mechanics of the breathing. So like increased respiratory effort, recruitment of the respiratory muscles, whether it is an inspiratory or the expiratory, or the inspiratory muscles fatigue. And in addition, there is the contribution of the accessory muscles in the some COPD kind of the patient. So when we talk about the inspiratory effort, there is an increase in respiratory effort is frequently a descriptor of the dyspnea, both in the normal subjects during exercise and in patients with the COPD. When the muscles become weak or when it get overloaded, it can feel like a greater effort is required for a breathing. Similarly, the respiratory muscle recruitment, dyspnea may be the signal when there is a rib cage inspiratory muscle recruitment. Generally, what happens, the diaphragmatic muscles, they play a major role. But in some patients, when the muscles become weak, so the inspiratory muscles recruitment also occur. Expiratory muscle recruitment also occur. So this causes a sensation of the dyspnea or the perception of the dyspnea. The other mechanism behind the dyspnea due to the muscle is the weakness. As we know that respiratory muscle weakness, any muscle, whether it is a inspiratory or the expiratory muscles, when it become weak, so more effort is required to drive a weak muscle than a strong muscle. Similarly, the patients of the COPD, especially I will talk about, they are at the dynamic hyperinflation. So what happens at their diaphragm is at the disadvantage point. So it is not able to generate the enough force. So that also causes a sensation of dyspnea. Other factors which can cause in the respiratory patients because of the muscles is the use of the accessory muscles like the neck or the muscles surrounding the shoulders, which can get recruited and may cause the sensation of dyspnea. Similarly, the patients, as you talk about the COPD patients, their quadriceps muscles become weak, their leg muscles become weak. So when they walk, when they get up from the chair, so what happens that they require more effort, they require more power, and that's why that even causes a sense of the dyspnea. So all these factors, there is a physiology involved for the muscles behind the dyspnea.
Wow, that was a wonderful answer. Why it was wonderful? Nowadays, there is a trend of paid master classes, schools of excellence. So, all of you who are listening to you, Dr. Pawan was giving you a complimentary master class. So, that was wonderful. So, when I was doing my residency at Delhi, I used to go to this place, Connaught Place, to have biryani. Then I had a patient who was a pilot. He told me, what, sir? One day you get up early and I will fly you to Hyderabad and you have biryani and could come back to Delhi by evening. So from Delhi now I'm moving to Hyderabad. I would ask Dr. Vijay Chennamchetty, sir, kindly enumerate the respiratory conditions where we anticipate sarcopenia.
First of all, uh, that was a brilliant talk, Atri Bhai. Okay, I thoroughly enjoyed. So you have covered most of the very, very valid and important points in your talk. And the way you delivered, it's a master class. Really kudos to you. And coming to the question, where all or which conditions we tend to see the sarcopenia. First, we need to understand the basic rule that any illness in the respiratory system which tend to become chronic, that can be probably beyond a few weeks, maybe 2 weeks, 3 weeks to and beyond. That can be COPD, that can be ILD, or for that matter, that can be cough, okay, chronic cough. So like that, anything which tend to become chronic will be associated with sarcopenia. Example, in your talk, you said very clearly, COPD cases tend to have more incidence of sarcopenia. They vary from probably around 15% in early stages of COPD or pre-COPD to as high as close to around 55-60% in severe COPDs. And the moment these patients tend to have exacerbations, whether it is ILD exacerbation or COPD exacerbation, they tend to lose the muscle mass very, very rapidly. And coming to interstitial lung disease, it is very common comorbid that the sarcopenia, unless we address properly, it becomes a very, very huge menace. Infections like where we can see these infections in outpatient, like tuberculosis, community acquired pneumonias, they tend to also have nutritional deficiencies and also significant sarcopenia. We should also remember sarcopenia plays a very, very crucial role in ICU admitted patients, those who are on mechanical ventilation, non-invasive ventilation, and also those who are on ECMO. Because there now, I can tell you, we have a patient who is on ECMO. Now, we tend to focus on increasing his respiratory strength, because this patient, we have placed him on ECMO just to ensure that it is as a bridge to transplant for an end-stage lung disease. So now we are fighting to improve the muscle strength on this patient so that he will be fit enough for a transplant. Other chronic lung disease, what we come across is post-tubercular bronchiectasis, and cystic fibrosis. Though cystic fibrosis very, very rare phenomenon, but the chronic recurrent exacerbation leads to significant sarcopenia. There is, interestingly, obstructive sleep apnea patients, they are exhibiting because of intermittent hypoxia and metabolic dysregulation. There is a significant impaired muscle strength in these patients. And last but not least, our neurological patients who present with obesity, hypoventilation, myasthenia gravis, and Duchenne muscular dystrophy, other muscular dystrophies. These are the patients, the Down syndrome patients. These are the patients, they have significant sarcopenia as a comorbidity. Unless we identify and address, it becomes an impossible task in our patient. So as per I said, so various examples, I think all chronic patients from cough to lung cancer, they have sarcopenia.
So, wow. So, Dr. Chennamchetty, he is also basically a professor at Apollo Medical College. So, all the young people who are listening, please take care that whenever you're managing these complicated diseases, which he told, kindly think of sarcopenia, that why the patient is not getting better. Suppose you have covered all the bases, but you're not getting desired result. Please think that are you also dealing with sarcopenia? So great, Dr. Vijay sir. Now I would want to introduce Dr. Suyash. Now, whenever we see the map of Maharashtra, it is so huge that half of Europe will fit inside that. And Maharashtra is so large that from Mumbai, the next two neighboring capitals like Ahmedabad and Panaji are nearer than parts of Maharashtra itself. So, Dr. Suyash, can you please tell us a little bit about primary versus secondary sarcopenia?
Yes, sir. Thanks. First of all, as you previously described, as a sarcopenia is a by the definition, it is progressive generalized skeletal muscle disorder, mainly muscle strain and mass. So sarcopenia is primarily divided into two parts. First is a primary sarcopenia, and second is a secondary sarcopenia. Primary sarcopenia, by the definition, it's when muscle loss occurs purely due to the age-related factor without any comorbiding factors. We label it as a primary sarcopenia. Second is secondary sarcopenia, when there is the comorbid factors associated. It's the main reason for the muscle loss. We label it as a secondary sarcopenia. So mainly causative factor for the primary sarcopenia is age-related factor. When aging is happens, there is 4 to 5 causes happens. One is neuromuscular aging that affects the muscle resynthesis and muscle metabolism. Second, as aging is happens, there is decrease in hormonal production like growth hormone, like testosterone. So when there is decrease in production, they affect the muscle metabolism. Third is as aging is happen, there is mitochondrial dysfunction is happening that decreases the energy production for the muscle. Fourth is the chronic inflammatory cytokines release. As aging is happen, there is continuous releasing of chronic inflammatory cytokines that hampers the muscle synthesis and repair. So these are the causative factor pathophysiology for the primary sarcopenia. And then we are moving to the secondary sarcopenia. Secondary sarcopenia is loss of muscle due to something which having etiological factor. So what are these etiologic factor? One is activity related etiological factor. Means if there is activity, if there is person or patient who has less active, who is bedridden, who has prolonged after surgery patient having bedridden, having less activity and less muscle utilization, is going to have muscle mass reduction and muscle agenesis. So we will label it on secondary sarcopenia. Then there is some disease related sarcopenia, when there is a chronic disorder like COPD, CKD, heart failure, or any cancer related problem that affect the muscle metabolism and muscle regenesis, that causes the muscle mass decrease and muscle strain decreases. So we will label as a secondary sarcopenia. Third cause is the nutrition related, when there is a low protein intake or any low amino chain acid intake, or there is nutritional deficiency related, then we will label as a secondary sarcopenia. And last is any GI disorder where we have malabsorption syndrome, or any GI disorder where we loses protein and loses all amino acid minerals. This also come in the secondary sarcopenia.
Wow. So basically what Dr. Saab wants to give the message is that if it is disease related, then sometimes treatment of disease can also help in the sarcopenia. But if it is something primary and the patient has another disease, let's say someone has primary sarcopenia, but the patient may be anemic, needing hemodialysis, CKD, then despite treatment of the disease condition, the sarcopenia may not improve. So that is why differentiation between primary and secondary becomes very important. Since this topic is a little bit not discussed in mainstream programs, we have lots of audience questions. We have Dr. Harendra Thakkar from Ahmedabad, Gujarat. He is a very active member in CCI 1 and he is found in lots of conferences. And I use this platform to appeal to you. It is a long time. Please become a CCI member. CCI will enjoy when you will become a life member. So Dr. Harendra Thakkar is asking that what may be the role of decadurabolin in sarcopenia? Any of our panelists want to take this question? Role of decadurabolin in sarcopenia.
So basically, it is an anabolic steroid, Vijay. Okay. So there is a lot of catabolism. Of course, in the upcoming slides also we are going to discussion about the same thing. So a lot of catabolism that happens because of a lot of inflammatory mediators, tumor necrosis factor alpha, IL-6, and all these chemokines, which play a very crucial role in catabolism. So to counteract this catabolism in COPD patients, anabolic steroids does have some significant role while managing COPD. But is there any gold guidelines recommends anabolic steroids? It's no. That is academically, but when nothing is working in a patient with COPD gold E category, probably it is worth trying anabolic steroid. And I do try in some patients, but there is no recommendations from the gold guidelines, which we need to remember.
Yeah, so means I would also pass on this message that if you're practicing as a specialist, please respect the guideline and please try to practice with the guideline. Only in desperate patients where nothing proven is working, think of these options with maybe a proper consent also. So great. Now I would want to ask Dr. Pawan. We have been talking a lot about the lungs and sarcopenia. Please guide us regarding certain extra pulmonary conditions where sarcopenia can occur. Dr. Pawan.
Yeah, sarcopenia not only affect the pulmonary conditions, but also extrapulmonary disease also, like as Dr. Suyash has mentioned about the chronic kidney disease, heart disease, cancer, HIV, obesity. So a lot of inflammatory conditions with a lot of chronic disease like the connective tissue disease like rheumatoid arthritis, inflammatory bowel disease. And the primary physiology behind all of these is the increased inflammations. Similarly, with obesities, there is increased inflammations exacerbating the muscle loss and the deconditioning of the muscles. So in addition to this, if we are talking about the any, whether it is an extra pulmonary or the pulmonary, so there is always a role of the malnutrition and as well as the poor oral intake and inactivity, as mentioned in the last question. So other than this, there are certain drugs which we sometimes forget that it can also lead to the sarcopenia, as we see in the patients of the ICU, like in critical care myopathy, right? So there is, we are giving them the aminos like aminoglycosides, the oral corticosteroids. So all these can also lead to the muscle wasting. There is an increased catabolic and increased proteolytic activity basically. And similarly with the anti-diabetic drugs, statins, there is a lot of data now we have regarding the statins, which can cause this kind of conditions. And if we talk about the COPD patients, so there is not only role of because of the airway disease or the pulmonary disease, but also because of the extra pulmonary comorbidities. Because more than 50% of these patients have some form of the comorbidities like diabetes or the heart failures, which can also contribute to the sarcopenia. So that's why it is always important to see the component of the extra pulmonary components also, drugs, as well as the in addition to the pulmonary component when we are talking about the sarcopenia.
Great answer. Great answer. So now, whenever we are talking about drug development for a chronic condition, we know that we may not be able to eradicate this condition. So this drug development investigates the various pathways, that if we know the pathways of pathogenesis, these new drugs will try to act on those pathways. So Dr. Vijay sir, what may be the specific pathways or factors causing respiratory sarcopenia?
This is very, very pertinent question, Atri bhai. So, as I was mentioning regarding when we discussed about decadurabilin, so there is a huge amount of catabolism that happens because of inflammatory mediators, particularly IL-6 and TNF alpha, which we need to remember, understand, and mitigate their side effects by enough measures. What is that? Those measures we will discuss in the upcoming discussion. So, and Krishna in his addressing this webinar, he also mentioned very clearly it is a vicious spiral rather than cycle, that physical deconditioning and inactivity in these patients will brood more sarcopenia. Sarcopenia broods more amount of physical inactivity, and that chain has to be broken down at any cost. Otherwise, we cannot expect any better outcomes in our COPD patients. More importantly, most of our patients, either they must be having hypoxemia or hypercapnia, or few patients they may have both the hypoxemia and hypercapnia. That can cause a lot of impaired mitochondrial dysfunction. If you look at the oxygen cascade from top to bottom, though the atmosphere air consists of 21% of FiO2 consists of, which carries roughly, which equals to about around 150, 160 mmHg. But when it reaches to the mitochondrial level, so it is around 5 mm of Hg. So this oxygen cascade, my dear friends, please understand. So in already pre-existing hypoxic patients of COPD, the mitochondrial level, there is huge deficiency of oxygen, which ultimately leads to a lot of cellular injury. Many of our patients, they are having, are poorly managed, their nutrition levels is least addressed. Whatever they eat, they maybe eat a lot of rice, lot of wheat kind of thing. That may not be contributing for any amount of their, energy requirements, protein requirements. That we need to understand. In India, to my best of knowledge, of course, the post-COVID era, we can say the scenarios are changing. Importance of respiratory specialists is being appreciated by a lot of common man. But please, when you recollect 20 years back, there are a lot of patients in government hospitals where majority of us got trained. So they stay in the close to emergency places, and then early morning when they had their COPD exacerbation, they'll get a glucocorticoid dose, probably Decadron, Derifilin, these kind of shots, or prednisolone, methylprednisolone, these kind of shots. It was a very, very common phenomenon in particularly majority of COPD patients during winters. These glucocorticoids also can lead to sarcopenia and associated comorbid conditions, which I thoroughly enjoyed the COPD Part 4 webinar, which dealt very thorough about the management of comorbidities in COPD patient. So in that webinar, I discussed very clearly about the role of managing nutrition in COPD, age-related muscle decline, that is primary sarcopenia, which was dealt beautifully by Dr. Suyash Patil, hormonal and metabolic dysregulation leading to a lot of cortisol levels in the blood, and then insulin resistant, decrease in hormones like testosterone. These are all can lead to significant sarcopenia. Psychological factors, which we don't consider in our patient at all. Okay, I'm sorry to say, one of the most important thing, presence of depression is lead to a lot of inflammatory disturbances. Associated comorbidities like diabetes, CKD, CLD, and so on can lead to malignancies, which is very, very common. Recurrent exacerbations is very, very common. So that all these factors we should consider, and then only we can say the respiratory sarcopenia can be addressed when we comprehensively look at all these factors.
One point I would want to single out from here for our audience is that whenever we are thinking of that frequent exacerbation, we think of compliance, technique, air pollution, viral infections. Start thinking about nutritional problems. Start thinking about psychiatric problems. Maybe you can help in that next exacerbation. Great answer. Now, Dr. Suyash, Dr. Chennamchetty told us very beautifully about these various pathophysiological factors. So, Dr. Suyash, kindly guide our audience that what may be the adverse effects of respiratory sarcopenia?
Yes, as sir has beautifully explained earlier, respiratory sarcopenia, in respiratory sarcopenia, mainly respiratory muscles are involved. There is decrease in respiratory muscle mass and function. So we know that in respiratory muscle, diaphragm is a main respiratory muscles with intercostal muscles and accessory muscles help in the respiration. As these muscles, there is loss of these respiratory muscle that reduces the uh, respiratory muscle strength, that causes decrease in tidal volume and decrease in maximal inspiratory pressure and maximal expiratory pressure. So these condition leads to the dyspnea and exertional dyspnea. Second thing, as respiratory muscles weakens, it decreases the lung volumes and capacity. It decreases vital capacity and it decreases FEV1. So it mimics or worsen the respiratory condition as a restrictive pattern. Third point is, as muscles is a main factor to in the curve reflexes. So as respiratory muscle become weak, the curve reflex become weak. So there is clearance of airway hampers and accumulation of mucus will increase. So these factors will subsequently increase the exacerbation and COPD like factor. Fourth point is, as respiratory muscles become weak, it hampers the curve reflex. As it hampers the curve reflex, there is increase of chances of respiratory infection due to respiratory muscle weakness. Fourth point is, as respiratory muscle become weak, it causes exertional dyspnea and it decreases the exercise tolerance. As respiratory muscle become weak, it causes hypercapnia and hypoxia and also leads to the respiratory failure. Then as respiratory muscle become weak, it increases the hospitalization and in mortality condition of the patient. Lastly, as if we don't have any good respiratory muscles, there is decrease of chances of poor recovery condition from respiratory illnesses or post-operative patient. So these are the all side effects of respiratory sarcopenia.
Wonderful. One point which I would want to single out from here is hypercapnia. See, whenever a COPD patient develops hypercapnia, now it points towards a poorer prognosis compared to other stable COPDs. So one reason for hypercapnia, kindly think of sarcopenia when you have covered all other bases. I would want to move to Dr. Pawan, sir. We have understood the pathophysiology, complications, etiologies, and various diseases. Kindly tell us, Pawanji, the tests to diagnose sarcopenia.
So, sarcopenia basically it is diagnosed by assessing the muscle mass, muscle strength, or physical performance. So, whenever we talk about diagnosis of the sarcopenia, it seems that the tests are very costly and they are very difficult to perform. But trust me, the tests are very cheap and they can be easily performed even at the OPD practice. So diagnosis is made when there is a combination of the muscle mass. First, there is a low muscle mass and either low muscle strength or the low physical performance. So to diagnose or to label the sarcopenia, one need to have confirmatory low muscle mass. And then we have the added either of the muscles, low muscle strength or the low physical performance. So now we have the certain test for assessment of the muscle mass. Like most commonly used test which we do in our clinical practice are the DEXA scan or the bioelectrical impedance. So the DEXA scan is having some more cost as compared to bioelectrical impedance analysis. So bioelectrical impedance is cost effective, can be easily performed, but the if we need to know the more about the body composition like the fat mass, protein mass, lean mass, then and even the bone mineral density, because sarcopenia in many times, or I will say the more than 90% of the time, is associated with the osteoporosis. there is a decrease in the bone mineral density. So that's why if we need to diagnose the sarcopenia as well as the osteoporosis, so DEXA will is better. Now we talk about the CT scan or the MRI. So they have even a good validity because they gives the more anatomical details and give the skeletal muscles volume. But their issue is the availability and they're more costlier. So after this, now if you talk about the muscle strength, so it is very simple test for muscle strength assessment. One need to go with the hand grip strength test. So that is very simple. Used to be done with the handheld dynamometry. And other than this, there is a 5-chair stand test where we ask the patient to stand from the chair, and it basically assess the muscle strength of the quadriceps muscles, our lower limb muscles. Then assessment of the physical performance, and it is also very simple test, that is by the gait speed test, and it is the time which is required for the patient to move certain distance at a normal pace. So out of these, the gait speed test or the this hand grip strength test, they are very easy to be performed. So according to the European Working Group on the Sarcopenia, they have advocated that firstly we need to label whether the patient is having a lower muscle strength or the lower physical performance or not. So go with the either gait speed test or the hand strength test. If both are come to be low, then now move to the more costlier test, like the to see the muscle mass. That is the either DEXA scan or the CT or the MRI. So if we talk about the diagnosis regarding the sarcopenia, so the tests are very simple, easily performed, and very cost effective.
So that was a wonderful and very elaborate answer in a very short time. When all of us were in class 12 preparing for a medical entrance, we had all memorized that even if someone used to wake up at 3 o'clock in the morning, that what is mass? We used to say mass is equal to force by acceleration. But after this webinar, all of us pulmonologists should know that if anyone asks us what is mass, start thinking of sarcopenia. So from physics, we need to think about muscle dynamics. So I would want to ask Vijay sir that kindly tell us a little bit about this dyspnea assessment scales, which can help in screening sarcopenia. Dyspnea assessment scales.
The, the way Pawan has explained is beautiful. And coming to dyspnea assessment scales, the routine MMRC systems and Borg dyspnea scales, they are the common things which we assess in our clinical practice. And then particularly in COPD, to be precise, CAT score COPD assessment test plays a very, very crucial role. And please do remember, presence of dyspnea may signal the impaired respiratory and peripheral muscle performance. And then it is time that it is not that only the obstructive airway disease that is being managed. We should focus and then use our various objective measures, like as I mentioned, MMRC, Borg scale, and CAT assessment score, which we should increasingly use in our clinical practice, so that early identification of persistent dyspnea can be objectively measured, so that we can monitor the dyspnea scores in clinical practice. And then if you say it objectively, that means MMRC2 has become better, and then our MMRC4 has become to 3 or 2. So that kind of thing, if we show it to the patient, it becomes increasingly convincing for them to understand. Because as Dr. Atri was sometime back mentioning, so some patients, their FE1 would have been from 45 to improve to 55 or 60 as well. But they feel, okay, I am not doing well, sir. But if you document them with a 6-minute walk test, if you document them with a CAT score that they are getting better, then they will get easily convinced. And probably these are the patients where your treatment is working, but still psychologically they are not doing well. Or sometimes if they are not doing well, then probably involve them in the improvement of sarcopenia, and by nutritional methods and also by rehab methods, so that they will start getting better. This is in short.
So we have lots of audience comments, lots of audience question. We have a question, Dr. Pramod Shukla from Mumbai, Maharashtra. Thank you, Dr. Pramod, for your precious time. What is role of esomeprazole? Any of our panelists would want to answer what may be role of esomeprazole in such patients? Dr. Chennamchetty.
Yeah. See, we again, who was the one who asked Atribai?
Dr. Pramod Shukla, he's from Mumbai, Maharashtra.
Dr. Pramod, this is one of the fantastic question. I will, for convenience sake, I will change esomeprazole to proton pump inhibitor, or for that matter, management of GERD in respiratory patients. It is very, very important to address GERD patients, GERD as a comorbidity in chronic respiratory issues, particularly COPD and interstitial lung disease, and also asthma as well. Because unless we manage APD, that is acid peptic disease, and associated gastroesophageal reflux, it is very, very difficult to control the exacerbations. So that's why all PPIs, okay, can be used at a moderate or as per the requirements we can use in our clinical practice. But again, please do remember the APD component can be decreased with esomeprazole or pantoprazole or whatever rabeprazole, but the reflux component cannot be managed. Unless we manage that reflux component, the exacerbations cannot be made better. So most of these patients, they may require additional prokinetic agent or anti-reflux measures should be installed in practice so that the exacerbations will come down, and then ultimately they will start feeling better.
Thank you. And that's a very good answer to everyone. Now, I would want to move on to Dr. Suyash. When we were talking about the pathophysiology, a lot of stress was given on undernutrition in these patients. So, Dr. Suyash, kindly guide us on the dietary role in tackling sarcopenia.
Okay. Sir, in dietary role, diet is the main key factor in both way for the treatment perspective and for the preventive perspective in sarcopenia. So in diet, there is a main factor is a protein intake. So protein is a main factor for the muscle synthesis. So adequate protein intakes causes the building of muscles. So protein intake by the guideline, protein intake should be the 1 to 1.2 gram per kg per day for the adult healthy person, and 1 to 1.5 gram per kg per day for the sarcopenic or for the diseased person. So protein intake, main protein in any forms, mainly in a egg, dairy products, soya or legumes have high quantity of protein. So we advise this kind of diet for the sarcopenic patient. Second is a branch chain amino acid, mainly leucine. Leucine is a main factor for the leucine contain the it activated the mTOR factor, which is mainly for the muscle proteins, which help in the muscle protein synthesis, which activate the muscle formation and muscle metabolism, muscle anabolism. So mainly leucine is in we advise 2 to 3 grams per meal for as a leucine. Leucine is rich in eggs, tuna fish, soya, and whey proteins and lentils. Third is vitamin D. Vitamin D is essential form. We advise patient to get it from the sunlight and fat fish. So dose of the vitamin D is 800 to 1000 international unit per day. Then fourth component is a omega-3 fatty acid. Omega-3 fatty acid has a main antioxidant and anti-inflammatory component. It increases the anabolism of muscle. So, 1 to 3 gram per day is the dosage form of omega-3 fatty acid. Third factor is creatine. Creatine is the increases the ATP production in the muscle, and it acts as an energy source for the muscle. So creatine is the main component. We advise 3 to 5 grams per kg per day as a creatine. And fourth is the multivitamin supplement. Multivitamin supplement, vitamin E, vitamin C, zinc, and selenium, which act as a antioxidant, which helps. So these are the dietary supplements we offered in the sarcopenic patient.
Wonderful. One thing I wanted to appreciate, Dr. Suyash, is lot of us clinicians do not know too much about dietary medicine. We trust and rely too much on dietitians and nutritionists. But after your discourse, I felt that if we clinicians know the diet properly, then only we and the dietitian can work better. And if we blindly leave it on the dietitian, there will be some missing gaps. So I appreciate you on driving this point home. We have received a compliment from Dr. O.P. Sharma from Delhi, very good CME on an important topic. My compliments to the entire team. I do have a chapter in textbook on sarcopenia in principles and practice of geriatric medicine. So that's a wonderful compliment that someone who is the author of a medical textbook, he is also listening to us. Now, Dr. Chennamchetty sir, whenever we are talking about COPD, without spirometry, there cannot be any discussion on COPD. So even in sarcopenia, please tell us what may be the role of spirometry in sarcopenia. Chennamchetty sir.
So, a very, very interesting question again. The way you moderate makes us to take or touch the true passion in delivering the answers. So, wonderful moderation, Atri Bhai. So, coming to first of all, the importance of spirometry in our practice, we should also remember that we are dealing on the one way it is sarcopenia, and then on the other hand, we are also handling, or this will be the closing webinar for COPD entire webinar series. So, on that note, what I would say is spirometry is the sine qua non test or gold standard test to diagnose COPD, or for that matter, obstructive airway disease. So, FEV1 by FVC should be less than 0.7. That is standard, and then followed by, it also helps in based on the FEV1 levels, what is the severity grading. So those are the first 2 points that spirometry is going to help in diagnosing the COPD. And coming to in sarcopenia, a low FVC and low FEV1 will always be associated when the muscle strength, that is diaphragm, is weak, when inspiratory muscle strength is less, then or expiratory muscle strength is low, then the patient cannot perform a spirometry invariably. This leads to low FE1, FVC values. And PFR in such patients where PFR can be tried as a surrogate marker, but again it is not time tested one. And coming to this low spirometry values are well in correlation with the physical frailty scores and also the low functional reserve. And spirometry will become an essential tool in monitoring the response of correction of COPD and also the associated sarcopenia. But remember, my dear friends, as a tool, so spirometry alone may not be sufficient in sarcopenia evaluation. It needs to be combined with other methods as discussed by my dear friends earlier, that is measurement of hand grip strength, chair stand stress, and bioelectrical impedance, and also probably DEXA scans. These are the associated things which we need to. But spirometry is as a term which we also use in a different way, like usage of therapeutic thing, that incentive spirometers in practice. I would like to add because we also use the spirometry term there. So they are very, very important in practice. Addition of incentive spirometry in our chronic respiratory patients will facilitate deep diaphragmatic breathing. Ultimately, this practice of deep diaphragmatic breathing will enhance the muscle strength and promotes the re-expansion in patients who are ICU and also chronic comorbid patients of COPD and then asthma, ILD. That will improve the atelectasis, improve the VQ mismatch, and it also acts as a very good muscle training stimulus for inspiratory muscles of particularly intercostals and diaphragm. Over to Atri Bhai.
Thank you. I just received a message from Dr. Krishna sir that this webinar currently has live 2,980 people watching us. 2980. That is a huge number. In fact, we were supposed to do this webinar last week, but the King and Queen of England had specifically requested Krishna sir to do this after Wimbledon, or their attendance of Wimbledon would have dropped because of this CCI Sarcopenia webinar. So 2980 is a great number, and we express our gratitude to the audience out there that it has been 5 years, but you are supporting us every Thursday. Thursday is a working day, but you come home at 8 p.m., or you are still at the hospital at 8 p.m., or you're in traffic at 8 p.m., but you watch our webinars. So thank you for the encouragement, respected audience. I would want to move on to the next question. See, spirometry, OAD, spirometry pulmonary is something which we can never do without. So however advanced you become, whatever advanced cases you see, always keep that spirometry in mind. And as Dr. Chennamchetty told, that here spirometry has a therapeutic role in the form of incentive spirometry also. There was a very brief mention about psychiatric disorder worsening COPD cases. So Dr. Pawan sir, what may be the role of depression in propagating sarcopenia and vice versa?
So this is a very important comorbidities, that is the depression. So but we see that both are having a bidirectional relationship. So if any patients who become inactive because of the sarcopenia, then there is a natural tendency for these kind of the patients to go into the depressions, because they become socially outcast from the society. They are not socially interactive, and what happens, they becomes more or less in later stage go into the negative thoughts and the depression kind of things. The reason why both are very closely linked, why they are closely connected, is because they share as some risk factors. Like both of these are related to the physical inactivity, unhealthy diets, and inflammation. Both conditions are linked to the increased inflammations, and there is also some role of the some neurotransmitters like the serotonins, which play a role for the muscle function and the mood regulation. So what happens when there is a imbalance in these neurotransmitter? It can cause the depression and the muscle wasting. Similarly, the lifestyle changes like the physical inactivity or the social isolation or the poor nutrition, both of these conditions share. Neurotrophic factors is also being studied, and it is the molecule that support the nerve cell growth and the survival. And the imbalance in these molecules or the factors may contribute to the sarcopenia and the depression. On the other hand, there is some studies also being conducted for the sarcopenia, which may adversely affect the mental function through anabolic and the anabolic and metabolic mechanisms. So why we need to think about both of these conditions together? Because when we think about the sarcopenia, so we talk about the interventions like the pulmonary rehab, which tackle the muscle functions, but we don't take care of the mental functions, mental well-being of the patients. So both of these go hand to hand. So that's why we require a holistic approach, effective interventions, where we can take care of the muscles and as well as the mood disorder or the depression. For that, we require the exercise, good nutrition, good diet, and a psychological support. So this is very important. These patients, they require not only the good diet or the exercise, but also the family or the social support for their well-being, and that will indirectly improve the sarcopenia also. So that's why both are interlinked. Over to you, Atri bhai.
Yeah. So one very beautiful thing you mentioned, this holistic approach. In pulmonary medicine, the biggest holistic approach that has come up in the last 1 decade is something known as pulmonary rehabilitation. Once upon a time, there used to be waiting list of doctors to get trained for pulmonary rehab at a very select few centers. But nowadays, thanks to certain app-based models, pulmonary rehab is on your telephone and it can be in the patient's home also. So, Dr. Chennamchetty sir, how does pulmonary rehab is helping in sarcopenia?
See, by this time, we have a very clear understanding that so management of sarcopenia is at least minimum twofold. One is nutritional management. Second is exercise training. This is where in pulmonary rehabilitation, generally, I must tell one thing. When we refer to our pulmonary rehab specialist, adjacent to pulmonary rehabilitation, they have within the department itself the nutritional specialists or dietary experts. They also sit together. So this comprehensive, as Pawan was mentioning very clearly, the combination of rehabilitation and then nutritional supplementation is very key in management of sarcopenia. This is going to build the endurance training. So it is going to increase the respiratory strength in this patient. Objectively, as I was discussing, it is going to increase the once it increase the muscle strength, the FE1s and FEC is also going to get better. And if we start measuring the 6-minute walk test, quality of life scores, VO2 max, they are all interrelated with the underlying sarcopenia. So, overall, another interesting point is the more the exercise they perform, eventually it leads to a lot of endorphins and enkephalins in the system, in the ascending reticular activating system that eventually lead to better moods, better amount of less depression, and then their overall performance becomes very enhanced. So thus management of sarcopenia through pulmonary rehabilitation has got a multitude of outcomes, good outcomes.
So that was wonderful. We have a question from Dr. Vijay Kumar from Daudnagar, Bihar. How can we diagnose sarcopenia? We have already answered this question, and I'm sure, Dr. Vijay Kumar, now you will be able to diagnose all the sarcopenias in Bihar, and you will definitely lead the management of sarcopenia in Bihar after this webinar. So thank you, Dr. Vijay, for watching us, and thank you, Dr. Vijay Kumar, for putting your question. Now, I would want to move on to Dr. Suyash. When you were talking about that wonderfully on that diet, you mentioned something known as a branch chain amino acid. It is very long, so we'll give a short form BCAA. At one point, I thought it was Bangalore Cricket Association, but when you told, then I realized it is not Bangalore Cricket Association. It is branch chain amino acid. So, kindly tell us what may be the role of this branch chain amino acid in sarcopenia? Is it a magic bullet? Is it that one cure that treats everything? What is it?
Yes, actually, branch chain amino acid has a very key role in the muscle metabolism. Branch chain amino acids mainly leucine, isoleucine, and valine. These are the three branch chain amino acid mainly act in the muscle metabolism, and especially in the case of sarcopenia. So these branch chain amino acid, mainly leucine, once they have three main functioning in the case of sarcopenia. First, these branch leucine is a key factor among these branch chain amino acid. Leucine stimulates the muscle protein synthesis by activating the mTOR factor. When leucine activates the mTOR factor, and it activates the muscle protein synthesis. Second thing is these branch chain amino acids support the muscle recovery. It slows the muscle degradation. In many age-related patient or any secondary sarcopenia condition, there is increase the muscle breakdown and inflammation. So these branch chain amino acid decreases the muscle degradation, and it supports the muscle recovery. Third thing is these branch chain amino acid decreases the muscle inflammation by decreasing the cytokine effect. In sarcopenia, as earlier discussed, cytokines are also inflammatory factors which degrade the muscles, and it is one of the positive factor in the sarcopenia. So these branch chain amino acid decreases the muscle inflammation by reducing the activity of cytokines.
Thank you. Thank you. Very good. In fact, I want to confess before the audience that when I took up the challenge to moderate this webinar, that was maybe the first time I also read about this branch chain amino acid. I also first time read about the hand grip cells. So when preparing for this webinar, taught me something new, which I'm sure will change my practice of COPD from tomorrow. So when I was talking about Bangalore Cricket Association, I got a question from Dr. Ishwar Prasad from Bengaluru, Karnataka. And I would want to ask Dr. Vijay Chennamchetty that Dr. Ishwar Prasad is asking that what is HMB? No, I'm asking Pawan sir, Dr. Pawan Gupta, what is HMB and how does it help? Dr. Pawan.
So when we talk about the essential amino acids, so then comes the HMB also. Basically, it is a derivative of the leucine. So leucine is the essential amino acid which is required for the muscle building, but it is not generally present in the body. We need to give it via diet. So the HMB is a derivative of the leucine. The full form is hydroxymethyl butyrate. So I have not used till now, but I have seen that the studies, and they have come to the conclusion very strong that it is having a positive outcome in the sarcopenia. When we discuss about the inflammatory, because sarcopenia somehow it is linked to the inflammation, so it decreases the inflammatory markers like IL-6, CRP, WBC. It even improves the pulmonary functions because it improves the respiratory sarcopenia, respiratory muscle functions, and also improves the immune functions and the myalgia. So it improves a lot of things. But the thing is that it need to be given along with the pulmonary rehabilitation or the exercise intervention plan. If we give it alone, then it is having very less effect on the sarcopenia as compared to when it is given along with the pulmonary rehab or the muscle exercise. Second thing is the dose. So what doses? So the conclusion is around 3 gram per day need to be given, and it is to be given for around 6 to 8 weeks length time. And it has been shown to increase the muscle mass building, decrease the muscle breakdown. And so when we discuss about the essential amino acids, so now we can even discuss about the HMB also.
So wonderful. To extrapolate this, I want to give example of a resident, brilliant resident, who tells his master or guide that I want to learn bronchoscopy, I want to learn thoracoscopy, I want to learn EBUS. Now the guide patiently asks, have you learned auscultation and percussion? The resident tells, no, why should I learn auscultation and percussion? Please teach me bronchoscopy and I will be very happy. So similarly, Dr. Pawan gave a very important message that the trials or published literature on HMB is definitely promising. But do give HMB, but always with pulmonary rehab, always with optimal medical management. Don't think that HMB is alone the answer. Just like sometimes we think that learning the interventions is alone the answer to becoming an excellent consultant, it may not be like that. Sometimes we need to go through the clinical methods first and then think about mastering the interventions. So now, Dr. Vijay sir, you always practice a dictum of I will never harm the patient. So whenever we are talking about a new pharmacotherapy, there is always this question of adverse effect. So kindly guide us that what may be the adverse effect of HMB, Dr. Vijay sir.
So, to my best of knowledge, Atribai, so it is a nutritional supplementation. I don't see any adverse effects for this HMB, and I'm willing to listen from my other colleagues as well, Dr. Suyash and Pawan, if they may add anything to the my answer.
Yeah, when it is given in the dose of 3 gram per day, so in the studies in the literature, but I have seen that it is not associated with any side effect, or because as you mentioned, it is a nutrition supplement. But when it is given beyond that 3 gram, definitely there are some kind of gastrointestinal issues or bloating or these kind of the effects. 3 gram per day for 6 weeks to 8 weeks is okay, and it is effective.
Yes, sir. Totally agree.
So thank you. We got another question. Dr. Naresh Chawla from Delhi, that what is the role of HMB alongside protein powders in cachexia? So I hope we have answered your question, Dr. Naresh sir, and thank you for your comment. Every question, every comment is an encouragement for CCI that we are going in the right direction. So now I would want to move to one, let's say it's a silly question from my side, that when we are talking about pulmonary rehab, Dr. Chennamchetty sir, what may be the restrictions of pulmonary rehab post an acute exacerbation?
Yeah, post exacerbation, it is a lung attack is not equal to heart attack. Please do understand. See, a patient who suffered a acute MI, we should not allow him to exercise. But a lung attack patient, that is post acute exacerbation of COPD or ILD, for that matter, asthma exacerbation, it is very important to subject them to a graded manner of rehabilitation, so that from the very beginning, I can say, from unless the patient is in on ventilator or high NIV dependency, or those patients who are having very high level of pressure support of NIV at home. So it is very important for all these patients to initiate the rehabilitation as early as possible. The rehabilitation need not that muscle strengthening exercise and all those things. Beginning of making the patient to attempting the patient to high sitting, attempting the patient to making him to walk and sit in a chair, providing the oxygen support during exacerbations, and then making him to walk. These are all small things which eventually will give a very good and long lasting results in our patients. That's why it is important to consider rehab as early as possible, even the patient is in exacerbation.
So that's a wonderful message. Often we confuse this lung attack with heart attack, and we may postpone something which can actually slow the recovery or not allow someone to reach the pre-exacerbation state. So if our audience wants to remember
Oh, one
every day,
important comment,
yeah, please.
Atri, one important comment. There is in Telugu one saying is there, or I would love to translate in English itself. If we cannot run a marathon, at least try and do finish a 10K or 5K, right? If you cannot do a 5K, do at least 2K. Okay. If we cannot run, walk fast. Brisk walk is encouraged. If the patient cannot brisk walk, at least he has to walk. Like that, a small amount of momentum in his life is very important as a rehabilitative measure.
Wonderful analogy. I would also want to reiterate the same, that every day is a good day to start investment or financial planning. Every day is a good day to plant a tree. Every day is a good day to gift flower to a lady. Similarly, every day is a good day to start pulmonary rehab.
Fantastic, fantastic.
That's great.
Yeah. So now, Suyash bhai, we were talking a lot about this diet health supplement. So what health supplement would you prescribe in documented sarcopenia cases, Suyash bhai?
Yes. When we come to the treatment and the supplementary part, again, as I earlier I have advised that we have to think for the protein in the in both manner, for protein in the diet and protein in the supplement. For dietary part, we have to advise that protein is rich in eggs, dairy products, soya and legumes. For the supplementary part, we have to advise the protein intake. For the amount is 1.2 to 1.5 grams per kg per body weight. Second thing is branch chain amino acids. We have to give the supplement of branch chain amino acid is the dosage is 2 to 3 grams per meal. And in diet, we have to advise that amino acids is rich in eggs, tuna fish, soya protein, whey proteins and lentils. Third part is vitamin D. We have to advise vitamin D in 800 to 1000 international unit per day. And vitamin D is it is given by sun exposure and fat fish. Third point is omega 3 fatty acids supplement. The omega 3 fatty acid supplement, the recommended dose is 1 to 3 grams per day. Fourth is antioxidant supplements. Antioxidant supplements are vitamin E, vitamin C, zinc, selenium. These are the multiple supplements we got by n number of brand names in market. Third is the creatine supplement. Creatine supplement, it increases the ATP synthesis production and it act as energy products for the muscle synthesis. The recommended dose for the creatine is 3 to 5 grams per kg per weight. Then the fourth is the calcium supplements and multivitamin supplements.
Wow. Thank you. Thanks a lot. Now, there is a question from Dr. Jyotirmay Das from Bargar, Odisha. Although this is not from the topic, that is there any role of antibiotic in asthma case? Dr. Jyotirmay Das from Bargar, Odisha wants to ask, any role of antibiotic in asthma case? Any of you want to answer? Most probably he means an acute exacerbation of asthma.
So most of the acute exacerbation of asthma, they are related to the viral, right? So if we are talking about the acute exacerbation of asthma, practically there is no role of the antibiotics. But yeah, if the patient is admitted and is on patient is admitted and is having multiple comorbidities in the past, one can give the antibiotic. But otherwise, as such, for the pure young patient acute exacerbations, there is no role of the antibiotic.
If I may add to Pawan Bhai has said very beautifully. But again, so when we look at phenotyping of asthma, we need to understand the broad pathophysiology. The pathophysiology is we have a T2 high asthma and T2 low asthma. So T2 high asthma, generally exacerbations occur and then steroids are the choice. T2 low asthma, where probably exacerbations can be managed with antibiotics. But again, the global lead of sputum inflammatory is Dr. Parmeshwar Nair. I asked your question, the same question, I think a few years back to Dr. Parmeshwar Nair from Canada. He said each exacerbation, even the patient may be T2 high or T2 low, you have to assess through sputum inflammatory. If the eosinophil predominant sputum inflammatory is there, then probably you don't need to use any antibiotic. But if you come across patient who has predominant neutrophil inflammation in the sputum, then these patients should be given antibiotic. And Parmeshwar Nair very clearly mentioned that if the sputum inflammatory is purely neutrophil predominant, then there is no role to add even steroid as well.
Wow. Thank you. Thank you. As we are trying to reach the end of this webinar, we must remember that this is the, let's say, final episode of our COPD webinar series. So, Dr. Vijay Chennamchetty, you had designed this COPD webinar series. So, kindly give us a update or summary that what we should all take home from these 10 episodes. Over to you, Dr. Vijay.
Yeah, just a second. Any pending questions, Atri bhai, we have?
No, we have covered all.
We have covered, right? Just a minute. So, before pulling out the leaf, which I have made a note here. So, first of all, huge congratulations for CCI for this COPD webinar series, because indeed this COPD webinar series, which ran for 10 sessions, so with close to around 52 faculty so far have visited our COPD webinar series and have given their experiences in individual in their own discipline. So what the first series have started with pathophysiology and investigations. What are the key pathophysiology and investigations that we need to understand? That was moderated brilliantly by Mehul Bhai from Mumbai. So the second one was beyond inhalers. So that means this is the first time I think entire subcontinent has witnessed an exclusive webinar on beyond inhalers in managing COPD. That is purely Dr. Ashutosh has led this team, and then he has done deliberate, wonderfully about what is the role of oral medications in COPD. And coming to third one, so we call Dr. Rajadhar as king of pulmonology in entire India. So there is no doubt that Sir has led the webinar on that is series 3. Session 3 of this webinar series by Dr. Rajadhar, and that was breath, mastering the inhalation technique. That was a beautiful deliberation. And comorbidities in COPD, I was very, very fortunate enough. The hidden aspects of breathlessness and COPD care I have handled, and thanks to my entire team. And the fifth one was in-hospital management from of COPD patient, from emergency care to ward care to ICU care and back to discharge. This was beautifully led by Dr. Pratibha Singhal from Mumbai, and Neil Bai from Vadodara has done a fantastic job in sixth series, that is Breathe Again. That is making our COPD patients to breathe better. This is the first time I think in the world that smoking cessation and pulmonary rehabilitation have both combined and then formulated one good webinar, 2-hour session. So Neil has done and his team has done a wonderful webinar. And then seventh webinar series was by the debut of CCI webinars by Dr. Tilagavati ma'am from Chennai. So she made the webinar very, very interesting on that is what are the in-flight prescriptions for COPD and what are the high altitude recommendations, turning difficult journeys to confident travels. She did a fantastic job. And another phenomenal thing, the next webinar was done by Dr. Ravi Doshi and team, that is emerging therapies. The emerging therapies like biologicals, interventions. So biologicals recently, in recent guidelines, this is gold guidelines, they have updated the role of biologicals, that is anti-IL-5 pathway and suppressing the eosinophilic inflammation. And then interventions like what is the role of valves, what is the role of coils, what is the role of bronchial thermovapor ablation, what is the role of surgery like volume reduction surgeries, lung volume reduction surgeries. They have been done very well by Dr. Ravi Doshi and team. And one of the fantastic and mind-blowing webinar is ninth webinar that was done by Dr. Kapil Iyer, and he has become master in podcasting, and he has done a wonderful job of smart COPD care in the era of artificial intelligence. And none to say, and the most beautiful webinar which I took again part is moderated by Atri Bhai, that is the management of sarcopenia and COPD. What a fantastic 2.5 month academic activity we have experienced. I got very good reviews from my students and then various students from pulmonary postgraduates across India, that this one series, if they listen, that is close to 20 hours, if they listen, they can cover A to Z of COPD. Nothing has been left over, and they can completely clear their exam. And I'm sure obstructive airway disease, apart from leave about asthma, COPD, at least they will get 15% of questions covered from COPD. So I felt very, very happy for being a coordinator for this and director for this academic series. Thank you, Krishna Anna, and entire team. And then say it is not one man show, to be honest. So it was a beautiful team that works relentlessly behind this webinar series. And my good, I rather calling as a friend, I call Atri as always a bhai. Okay, he's my good younger brother, Dr. Ravi Dosi, Dr. Shivani, Dr. Kirat. So, Dr. Agambai, we work relentlessly and think always what else we can add, what new. In fact, at the roughly around fifth series, fifth session, that is in hospital management of ward to ICU, we had a confusion. Then me and Shivani were discussing for 10-15 minutes what else we can add to webinar series, and then that beautiful thought has led to another 5 parts that includes sarcopenia as well. So I'm truly happy for giving the conclusion remarks of COPD webinar series. Please stay tuned to COPD webinars. I'm sure you will get nothing but evidence, and you can cover a lot of syllabus in very, very short time. Over to Atri Bhai.
Yeah, thank you. I would request Dr. Pawan to give your closing remarks or take-home message on this sarcopenia.
So, sarcopenia, basically, firstly, we need to diagnose the sarcopenia, because the patients of the COPD which we see and we label them, we generally give the pharmacological treatment. But if we diagnose the sarcopenia, and especially the respiratory sarcopenia, then also they need to be given the pulmonary rehabilitation. And sarcopenia, it is very easy to be diagnosed by the even office test. And when we diagnose these tests, then we can need to have a good holistic and multidisciplinary approach involving the multi-specialties like nutritional, like the pulmonary rehab, and the psychological support.
Wonderful. Dr. Suyash Bhai, your closing comments.
Yes, sir. First of all, thank you for giving me chance to present this. Actually, we have covered almost all the parameters, all the conditions, all the treatment part, all the diagnostic part of the sarcopenia on this webinar. It is not possible to elaborate all the things, all the supplement regarding in just a few minutes, but all faculties have done their job excellently. So thank you to all.
One thing I want to say is Dr. Suyash has recently become a member of CCI, and this is his debut webinar. So one thing which CCI always believes is, which Dr. Krishna always tells is, that someone has to give the opportunity, someone has to give the stage, someone has to give the platform, and the best will come. Like, no job is no experience, and no experience is no job. So CCI wants to break this vicious cycle. anyone who is a CCI Life member, if you believe you have not got a chance yet for a webinar, please message us. We'll be very happy to give you an opportunity. If you believe that you have performed a webinar long ago and you have not received the second chance, please message us. We will happily take you. Third, if you believe there is a topic that needs a webinar, please message us. We are listening and we will take up your topic. Recently, during a webinar, there was a comment by Dr. Tridib sir regarding conducting a webinar on certain topic. And we searched our last 5-year library and we found that no, we had not done webinar on that topic. Immediately next week, we planned a webinar on that topic. We invited Dr. Tridib also to be a panelist. And even last week webinar had got very good hits. CCI is listening. CCI wants to give opportunity to everyone because at the end of the day, we are one big united family. Looking forward to meet all of you at CCI Con Kolkata, which is next month. Thank you, Dr. Krishna, Dr. Narayana, our current president, Dr. Ashish Dubey, secretary, Dr. Anil Maske. Thank you, the technical team, Vinod ji, Bijal ji, and everyone. Thank you, our academic partners, MEGHMANI Life Sciences. Thank you, my panelists. It is evident that last 2 or 3 days, you people have been reading very hard from the textbook, from the internet, from the journals, and you have done justice to a topic which was perhaps never discussed before. So from everyone here at CCI, a very good night to all of you who have logged in from India and Asia. Good morning, good afternoon to everyone who have logged from other parts of the globe. Thank you.
No, I echo whatever Dr. Atri said. Okay, we can close this.